Well, good afternoon, everybody joining. I'm going to just give it a minute or two, let people join. But thank you so much for joining us for another episode of Stewarts Soundbites. I am so lucky today because I have such a brilliant guest, Nicola Hunt, who is a chartered physiotherapist. She's got tons of experience in neurological, vestibular, and respiratory physiotherapy. She's really niche, really experienced speaker. Well, I say that I don't actually know whether you are a really experienced speaker, but it definitely comes across that way. And we had a, you know, we've heard from Nicola in our office, and I've seen other webinars and podcasts that she's done. So you're all in for a treat. Thank you so much for joining us, Nicola.
Thank you for inviting me, Emma. I'm excited to be here and chat to you.
Yeah, no, me too. And we have a topic today, which is, I mean, we're gonna struggle to cover absolutely everything that we'd like to, but I'm hopeful that we can kind of give everyone an overview of kind of the key issues. We're talking, excuse me, we're talking about kind of vestibular dysfunction post brain injury. And it's a huge topic. It's absolutely massive. But if we dive in, because we do have lots of ground to cover, Nicola, I'm gonna try my best to keep on point. Just can we just start with the basics? Nicola, can you tell us why why do people who've sustained a traumatic brain injury often encounter dysfunction or deficits in their vestibular functioning?
Okay, so there's a few reasons. If we think first of all about where the vestibular system is, so the vestibular system is in your inner ear, and it's basically made up of three semicircular canals in different orientations, and at the bottom of those canals sit some calcium carbonate tiny crystals. So then running from that, you've got a nerve running through to your vestibular nucleus, which is in the brainstem, sort of at the very bottom of the brain. So if you think about sort of trauma to the head, it's quite likely that it's also going to have some trauma to your vestibular system because it's so close to the brain. So when we're thinking about sort of vestibular issues after a brain injury, we're firstly thinking, is it peripheral? So is it something wrong with the vestibular system itself? Or is it central? So is it something wrong with the area of the brain that takes the information from the vestibular system, integrates it with all the other sensory information that we've got, and then gives a motor output to control our posture and our movement? So if you think about sort of the vestibular system and peripheral, then you're thinking maybe the crystals have been knocked into the semicircular canal where they shouldn't be. So that gives you a condition called BPPV, benign postural positional vertigo, where you've got those crystals in the semicircular canal. They shouldn't be there, so that you get this sort of spinning rotational dizziness that you feel every time you move your head in a certain direction.
Yeah,
Then you've got sort of the nerve coming off there. So we're still sort of thinking peripherally. We've got, the vestibular nerve that comes off there going into the brain. And again, that can be stretched and functionally interrupted the same as any other nerve with a brain injury. And I'm including MTBI or concussion when I'm using the word brain injury. And then you've got sort of more central issues. So where the vestibular nucleus is, so the information goes to the vestibular nucleus. We've got four in the brainstem itself. And then that information goes to the cerebellum, which again is at the back of the brain. So we're looking at sort of integrating all that information and then sending it out as a motor response. So any of those areas can be affected with an injury to the brain, particularly if it's traumatic. And then you've got sort of the other issues of sort of central nervous system, brain
yeah,
impairment as well. So it's thought, depending on which literature you read, somewhere between 30 and 50% of people with a brain injury have some sort of vestibular involvement.
wow.
And around 50% of those still have vestibular symptoms at 5 years. And it is an independent factor for return to work,
Yeah.
aside from the brain injury itself.
It's unbelievably common and complex and nuanced. It's not a case of, and I hear it a lot, in from the other side sometimes saying, it's a bit of dizziness and, kind of
Yes.
you it'll be fine sort of thing, which kind of underplays the seriousness of it for some people I know. And I should have said, sorry, that and if anyone wants to ask a question, just pop it in the Q&A box and we'll try to address it in the time that we have. I want to talk about identifying when somebody has vestibular dysfunction, Nicola, because I'm thinking about case managers and treating therapists, for example, because it's not necessarily, you can correct me about this, but it's not necessarily that someone's falling over and it's really obvious that there are problems at first, and presumably things might evolve. As you say, some people have them at 5 years down the line. So how is it that we go about identifying whether someone is suffering in this way, and when should a referral be made to someone like you?
So I think the first thing is, if the person says they're dizzy, then something is causing that dizziness, and it's most likely to be a vestibular disorder. Sometimes patients will sort of, it's difficult around terminology, and it's just about questioning, is it dizziness or is it lightheadedness? Do you just go dizzy, lightheaded when you stand up quickly, or is there sort of this background dizziness? But we know with brain injury that people get something called vestibular agnosia. So
Mm.
actually, they don't recognize the symptom of dizziness, which then
Yeah.
makes it really, really complicated. So things that you might sort of ask them is, are the balance issues, are they veering to one side sort of fairly consistently, which may be that there's a vestibular um, difference from side to side? Are they having falls? Are they losing their balance? One of the big, really key questions is, what are you like in the dark? And again, anybody can just say to a patient, with safety in mind, get them in a corner of a room with two walls sort of behind them and you standing in front of them so they're nice and safe. Can you put your feet together and close your eyes? And if
Mm.
they're really struggling with that, if there's a lot of sway, much more than with their eyes open, then it's a bit of a clue there's probably a vestibular impairment.
Yeah. And we were talking before this, Nicola, whenever we were preparing for this episode, we talked about problems in the dark and people who have such terrible problems, though not even on the worst end of the spectrum, but even a mild kind of disorder where they find moving around in the dark really difficult, which can be, extremely dangerous, particularly if someone
Yes.
lives alone or they're older. And you were talking when we spoke about this, we said that there are some really simple things that we can do to help with that sort of thing.
Yeah.
Um, and I think in that particular case, you'd mentioned someone just had an Alexa, or to turn lights on, or to,
Yes.
presumably that was a long-standing thing in that instance.
Yes, I mean, if you're struggling in the dark, if you don't have good balance in the dark, then you need to make sure you're not moving around in the dark. So some people will quite happily have a night light that they leave on all night to get up, so there is some degree of light. But other people like to sleep in darkness, and it is better for us to sleep in darkness. So
Mm,
having something like an Alexa where you can voice activate turning a light on if you ever need to get out of bed makes it much safer to be able to move around. But it's not just, getting out of bed. A lot of people close their eyes when they wash their hair. You put if you're in the shower, you put your head back, which makes you a bit unsteady anyway. You close your eyes to stop the shampoo going in your hair, in
yeah,
your eyes, and
yeah,
then you fall over. So it's again around sort of, making sure if you're going to do that in the shower, can you sit down in the shower? Or if you can't sit down in the shower, can you actually lean against a wall? So maybe not
yeah,
have the shower behind you, but have it at the side so you can lean onto a wall to anchor yourself for the times that you need to close your eyes to stop the
yeah.
suds going in your eyes.
Yeah, super scary and high risk, actually. Nicola, and important that it's addressed. And I mean, presumably, because you've already said that this is something that people themselves who are affected may not even notice it. So it's difficult, therefore, to kind of to pick up. I'm thinking for a treating team, for instance. You know, presumably it is something that's commonly missed, and is it safer to just presume that there may be a problem and have it assessed? Because the difficulty, of course, is doing something like that and then having a row about the costs of an assessment and all that sort of thing. So how do we address that?
I think the simplest thing is early vestibular screening. So, somebody who is trained in doing a brief vestibular assessment to look at whether there is any significant impairment or concerns around whether there's some vestibular involvement. And, sadly, it's not just, missed. It's often sometimes said that, well, we don't think there is any,
Yeah,
when actually that's said with people without the experience of vestibular
yeah,
conditions because they're missing the nuances.
Yeah.
So having a screening assessment, looking at sort of balance in all four conditions. So looking at, sorry, I'm going up there, looking at what's their balance is like with their feet together, what their balance is like with their eyes closed, what their balance is like on a compliant surface, and then asking those questions, what are you like moving around in the dark? What are you like in the supermarket, which is another real trigger for people with what we call visual vertigo.
Yeah. Yeah. So being out in the community, even with clients, patients, whatever, might
Yes.
is give you good insight as well. Um, so is it and this may be a ridiculous question, but is it something that may kind of evolve over time? Are these kind of symptoms ones that you would generally you'd see kind of immediately after a traumatic incident or an ABI of some description, or is it something that can evolve over time and suddenly become obvious later down the line?
It can be either.
Okay.
So, again, there is some research suggesting that, in the early days that we screen people for vestibular, but again, that depends on the complexity of their traumatic brain injury, if it was trauma, because actually these people may be in hospital for 6, 8, 9 months before they're even out into community. And they're the ones that probably it's not picked up early on because
Yeah.
there's so many other sort of more pressing concerns around sort of tone, balance, eating, swallowing, that maybe the vestibular isn't at the top of your checklist of what you should be doing. It
Yeah.
probably should be, but it tends to be the one that's left off.
Yeah, yeah. I'm just looking at the Q&A, Nicola, because Edward McGrail's inserted a comment says symptoms of a head injury are not always immediately apparent and often become noticeable over time as individuals observe specific signs. In one particular case I have, the individual exhibits all the symptoms despite being referred to various specialists. No one has connected the symptoms holistically to consider the possibility of a head injury.
Yes. So if you're talking mild traumatic brain injury, or as sport prefer to call it concussion, then yes, concussion symptoms can come on straight away, but it's probably just as common for them to come on over the first 24, 48, 72 hours. And then again, if people don't manage that well, then actually the symptoms can feel as if they're getting worse because they're doing the wrong things. And, a lot of GPs sadly are still giving advice that says you've had a concussion, rest, when we know that rest beyond the first 24, 48 hours actually exacerbates symptoms and is detrimental. So and there are becoming more and more concussion clinics springing up in the UK now, where you are getting that multimodal assessment, where they're assessing oculomotor, vision, uh, vestibular, balance, and then your other sort of symptoms, your autonomic symptoms, sleep, mental health, and putting it all in together as a sort of a management plan.
Yeah. I just wanted to go back to Nicola to you said you kind of mentioned kind of that early assessment and that's uh, you know a reality for lots of us that run legal cases and have funds for these sorts of things. But what is the position for a person who's affected in this way but has no legal help? There's no funding behind a legal action. Are there places that they can turn to for help?
Yes, so there is a growing sort of number of physios who are vestibular trained, and there is a website called the Association of Chartered Physios in Vestibular Rehab, ACVI, yes, Association of Chartered Physios in Vestibular Rehab, which does list where all the physios with a special interest in vestibular are practicing. So you can have a look for sort of local practices. They're a mix of private and NHS clinics. Then you've got sort of the route referral into ENT, and there are sort of ENT doctors who are specialising in vestibular conditions. And then similarly, you've got sort of neurologists who take an interest in vestibular conditions. From where I see it, one of the problems that we've got is vestibular isn't a speciality in itself. So you may be an
Mm.
ENT doctor who has an interest in it. You may be a neurologist who has an interest in it. You may be a neuro-ophthalmologist who has an interest in it. But it's a speciality with an interest rather than a speciality of its own, which I think is probably why it's not assessed and treated as well as it should be.
Yeah. I'm interested to know whether you've encountered, with patients that you've worked with, whether you've had any difficulties where there is someone, someone working on the vestibular issues involved, but also like, for example, an MSK physio. And I suppose I mean that in terms of overlap in the work that you're doing potentially, um, or any kind of row about funds, I suppose, in essence, from somebody saying, well, you've got two physios here, really. Do you have to spend a lot of time kind of justifying?
Not usually, no. I
Mm.
think the Chartered Society of Physio has a document around concurrent and practice. So two physios treating the same patient, and it's just common sense, good practice, really. You make sure you communicate, you make sure you discuss your goals, you make sure that there's ongoing communication between the two treating therapists. But we all need to stay within our speciality, and I think that's true with any profession. I
Yeah.
mean, Emma, you're working in sort of personal injury and clinical negligence. You probably aren't going and doing sort of surveying in your spare time if you have any.
I don't think that anyone would want me surveying anything. And I'm going to get told off because I'm running out of time, but I do have another question I wanted to ask, and I think it's an important one. And I think it's something that I've heard you speak about before, Nicola, very, very well. So I think it's worth asking. And that's just about kind of advances in technology in this area, because it's really come along. Technology's really come along in this area. So I just wanted to just briefly, if you could give us a kind of a whistle stop tour, a brief overview of how things have changed. And I actually do have some more Q&A comments, so I'll come
Okay.
back to them.
So I think sort of technology, it used to be that the vestibular lab sat in a sort of tertiary hospital and was very, very expensive. It's still expensive equipment, but there's a lot more sort of coming down to sort of smaller clinics and portable ones. So now we can be more objective in the way that we assess balance. We can use force plates so that we can actually measure the sway path in each of the conditions, because then we're not just saying, well, they look a bit wobbly. They look a bit more wobbly on that one. We're actually providing data to say, this is how wobbly they were with their eyes open. This is how wobbly they were with their eyes closed. But one of the big things that I use a lot is I have a VR headset, which looks at your ocular motor function, so your eye function and eye movements. And the reason that that's so important, A, is it can be affected independently after a brain injury without any vestibular involvement. But B, there is a reflex called your vestibular ocular reflex, as the name says, vestibular eye, which means that when you move your head, your eyes should be able to stay still. And that's really important for daily life, because if our eyes are wobbling as our head's moving, then everything feels a little bit blurred, a little bit out of focus. It's very hard to judge where objects are, if you're going to pick up your cup of coffee, or you're going to step up a step or down a curb. So having that reflex nice and sharp is important, and we can use sort of the VR headset to assess parameters of all of this, the eye functions, how they move and how the reflexes are responding. And then we can use the same headset for sort of gaming eye rehab to improve function, as well as a bit of a home program that's not quite so high tech.
Yeah. Another question. I'm going to get told off so much, but I'm just going to crack on if you don't mind, Nicola.
I did.
Because Edward's asked a really interesting question, which is, what does Nicola think about hyperbaric oxygen therapy for post-concussion syndrome rehab?
Currently, the evidence isn't supporting it, but anecdotally, a lot of people are saying it helps. And
Mm.
we know that after a concussion or mild traumatic brain injury, there is alterations in the blood flow to the brain, so that and we need to be able to increase the blood flow, and we need to be able to replenish the energy cell, the ATP in the brain, which is very depleted after a concussion. So if we can create parameters that are improving blood flow and energy availability, then it's going to help. But
Okay.
it's not categoric research out there. There's some interest in it, and people are saying it helps.
Yeah, yeah. And then just one other comment on it? Well, Edward also mentioned that Headway is a good place for sport. Depending on region, of course, they have good support and education as well. And then Jane Warbricks added ways in which we might flag vestibular problems day to day, and experiences in OT have been someone saying, I don't feel right, or missing the last stair, difficulty in filling in forms, which can be related to lifting the head up and down. And she has rightly said it's really important for everyone to know what to look out for so that specialist assessment can be sought. And I suppose this goes back to the point that, even those kind of seemingly mild problems might be end up or be completely debilitating for people.
Massively. And I think sort of the age group that we particularly see it in are people who are still at school. And you get somebody coming back after what the school consider a fairly mild head injury,
Mm,
and they're then struggling to complete their work on time. They're not focusing in class. And actually, we know that one of the things that happens is what's called our convergence point, the eyes that if we bring something in towards our eyes, we will at some point see two of them. And that should be fairly close to the face. But if you're seeing two of them out here, or you're seeing a blurred figure, then actually looking at your laptop, reading the text on it, reading in textbooks becomes really, really challenging. So sometimes it's just behavioural changes that we see in children, but the same in adults, difficulty filling in forms, just being what they would describe as, well, I'm a bit clumsy. I bump
yeah.
into things a lot because they're not
Yeah.
judging distances.
Yeah, it's
Yes,
hard to tease that apart, isn't it? Especially in children. I mean, I don't know about anyone else, but my 6-year-old has got bumps and bangs and cuts and
yes.
scrapes and whatever all the time, and it's just it's hard if you don't, if you don't know what you're looking for. But that was a great question, a great comment, Jane. Thank you. And Nicola, I could talk to you all day. I could keep you here all day.
It's
But
probably a topic I could talk about all day.
yeah. Well, you have a huge amount of knowledge, which is obvious. And one thing I would recommend to everyone watching is to find Nicola on LinkedIn because she posts some really good stuff. From a practice point of view, just general interest point of view. There's loads of good stuff on there. And I will make sure that after this we've linked Nicola into all of our posts. I think she has been so far, but sorry if you get a flood of invitations after this, Nicola, but it's a really interesting and really important topic. So I'm very grateful to you for coming on. And I hope everyone's enjoyed it as much as I have. Thank you, Nicola.
Thanks, Emma. It's been great chatting to you. I've really enjoyed it.
Oh, thanks. See you soon, everyone. Take care.
Bye bye.
Bye.